Chief 99 is having trouble with the speakers, so give us a second.
We'll give it a second. Okay, looks like they may have gotten it up. So I'll go ahead and get started. So for the Clayton people, this is going to be a little bit of a, this first part's going to be a little bit of a review, but just to give the Englewood and Union folk an understanding of what we do with the QA/QI review process. I know for Englewood and Union, it's not tremendously new, but as we move forward, we're trying to kind of meld together what we're currently doing and come up with a little bit of a better process and improve this this process of QA/QI as we move forward. As of right now, it is myself, Lieutenant Bacon, Lieutenant Shaning, and Lieutenant Stevens from Union, and Firefighter Stevens from Clayton. They're doing QA stuff, and we're hoping to expand that out a little bit to try to get a little bit of help from both Englewood and Union, and we're working on that to kind of bring some other people into it. A couple of the a couple of things with the process is that this is a completely objective view that we are looking at. We are looking at people's PCRs in different incidents. The form that's up on the screen now is the form that we actually use. You may see some different variations of this form as we move forward with our new medical director and medical directors, I should say, to see where they want us to change this form, if there's anything that they want to see on there or changed. But it is a panel review. Most of your calls, every single call is looked at. So collaboratively, you know, the 7,000 calls that we have within the collaborative in a year, every single one of those calls will be looked at by at least one person. And most of those calls, especially if it's a more intense call, if it's a cardiac alert, if it's a trauma, if it's anything significant, that actually gets more like a panel review. And that panel may even include some of the our medical directors as well. Understand that we're looking at these calls from 100% lens, meaning we try to look at these calls as what is the most perfect this call can be, the best possible treatment, no variations or fluctuations from protocol or standard of care, and that's how we look at it. And if we see those variations, then we start asking ourselves questions of, okay, if we have those variations, then why did we have a drift away from protocol or standard of care issue? And you may see things on these forums that are posed in a question of, why didn't we do this? Did we consider this? Those aren't necessarily there for you to answer. They're there as questions to ask yourself about that call. These are non-punitive. However, you know, if you do receive one of these, we do carbon copy your lieutenants on it, and the only reason that is so that they can kind of follow up and gauge where you're at. So if they see ongoing issues pop up on of the QA end of things, they can follow up with you and try to help you make those changes. But it is non-punitive, so don't fall down the rabbit hole of that, because we're not utilizing these for discipline at all. It is an assessment and improvement tool is all we're looking to gain from them. I can tell you over the past almost 2 years that we've been doing these in Clayton, we have seen an improvement in our standard of care, improvement of understanding of protocol, and it allows us to see trends of what we need to train on, and in the collaborative, it's going to allow us to see trends on what we need to come together and train on as a collaborative. Just a little bit about the process. The process itself is we kind of start by looking at the call type, the chief complaint, patient's age and sex, and then we look at your initial exam, your assessment, and your initial vitals to kind of put us on a path of what we should see in that call. And then that's what we're geared towards. We're looking at what we should see out of those factors documented in a call. And if we don't see those, that's when we're going to kind of question things and see if you've explained why we don't see those things. Treatment and procedure paths is kind of important on there. We see what you did, how you did it, what order you did it in, make sure it was the correct drug, correct dosages, correct care, and those are the different things we look at. And then to end with, we look at protocol compliance along with that, and did we document any variation or change in protocol. I've got 8 different calls here that we're just going to go through and review. I will apologize to the union people right off the bat, because I don't have any union ones in this time, but I promise you next time I will, and we'll have a little bit more of a vast array. So most of these are from Clayton and Inglewood. I'm still trying to get used to the ESO system, so as we move forward, and we are on the same system, it's also going to make this a lot easier. So you're going to see format in here from both ESO and ERS, and I'll kind of try to explain along the way those small variations in the reporting systems. As we go through this, feel free to jump in at any time with any questions. As we go through this, I may say, what are the QA/QI issues you guys see? Feel free to answer up, or you guys can kind of talk amongst your own groups, and then I'll kind of give you what, as a QA committee, we've determined to be wrong, to the different issues with that call. And like I said, feel free to unmute at any time and jump in there with any questions or comments on these calls. I have blocked out the names. I apologize if I've missed any names of care providers in it, but understand that we're not beating anybody up over this. This is just to make this is an improvement tool, assessment tool, get everyone to learn a little bit about documentation, standard of care issues. So the first call is 0021 hours. It was Medic 99 and Medic 98 for cardiac arrest for an 18-year-old female. So once again, as we're looking through this, I kind of look at that initial assessment area. As we look down through here, you saw the arrows pop up here, different things that kind of bounce out to us. So right off the bat, we see this is an unresponsive patient, that they're pale. We're documenting some type of a mass at their head or their face, which in the comments, it shows that it's a hematoma on the eye, on the left eye. Lung sounds, we're showing decreased on the left lower and upper side. Abdomen, we don't show anything, but we also show some type of a penetrating wound on the upper left arm. And then the other thing that kind of jumps out to me is that we don't have any assessment neurologically. So right off the bat there, as we look at those, start getting some questions in my head about what we're going to see. As I jump into the vital signs, I start looking down the vital signs, and I see, a starting pulse of 53 with a capnography of 30, and then that kind of bounces all over the place. We go into the hundreds, all the way up to the higher hundreds, 191, 165, and I see that Untitled drop all the way down, which obviously, if we're dealing with an arrest, showing us kind of a trend of not a viable patient. Also don't see any blood glucose documented. So I got a couple questions here. But other than that, it kind of starts leading us down a path of, what are the things I should see in this? Are we dealing with an arrest? So what am I looking for? So we jump in after that into I believe in the ESO, this is called the flow chart. This would be an ERS. This would be very similar to the procedures section. So I see we did CPR, we bagged a patient, we did an IO, we did a successful intubation, we put them on the Lucas, had them on a 3-lead, suctioned the patient, gave Epi and Narcan and atropine, a couple rounds of those, and then I also see that we did a decompression. So everything here, start looking, dosages all look good here. Didn't look like we had any issues with airway. Looks for the most part pretty smooth. Everything was successful. So now I've got, what are my questions of this call before I jump into the rest of the documentation? Well, number one is it's an 18-year-old in cardiac arrest. So why do we have an 18-year-old in cardiac arrest? Kind of painting that picture just from those initial areas that may be a traumatic arrest. So what are we dealing with? Blunt, penetrating, and then treatable causes. What's the treatable causes in there on any arrest? Because that seems to be a common trend, and it's not just with us, our individual departments, but it's in EMS in general in this area. I think we kind of go down the route of throw some epi, throw some atropine, throw a little bit of something else, and then we terminate. But are we truly looking at what the treatable causes are for these events? Hyperglycemia, hypovolemia, on down the list. And are we investigating those and treating those as they come along? Because a lot of those we do have courses of action to treat to try to reverse what's going on. So just something to think about there, and that's always going to be something we're looking for within this QA/QI process. So your narrative. Inglewood Crew's dispatch should address reference cardiac arrest. Upon arrival, female patient lying on the ground, pulseless and apneic. Bystanders state that they found patient lying here, checked for a pulse, but did not initiate CPR. States unknown downtime. Patient noted to be warm to the touch. No immediate signs of death. Patient placed onto cot. Manual CPR initiated and medic. Patient's original rhythm is PEA. While removing patient's clothing, noted 1 penetrating wound to the left shoulder region. Advised PD of findings. Patient intubated with a 7-tube. Positive for condensation, visualization, auscultation, capnography, chest rise and fall, and tube secured. External CPR device applied to patient. Patient ventilated at a rate of 10 breaths per minute throughout care via BVM. IO obtained ×1 in the humeral head. Patient became harder to bag with diminished left lung sounds. Patient needle decompressed. Left midclavicular line with improvement. Patient transported to Grandview ED en route. Patient given 4 epi, 3 atropine, 1 Narcan as noted. Per protocol, report given en route to ED. Assigned trauma room, rhythm checks en route to ED, noted asystole throughout. Patient began hemorrhaging out of the decompressed lung en route. No changes in patient status en route to ED on arrival. Patient moved to ED room, CPR still ongoing, given reports at ED doc, patient care transferred to ED staff. Just some screen grabs here of rhythm and capnography readings. So nothing truly significant here. We'll say one thing about capnography. So when I'm looking at capnography, just the difference between that waveform and this waveform, start to question that a little bit of something you may need to check our tube placement. However, I'll come back to that here in a second as well. So some of the questions we ask on all of these. Was protocol followed and documented? And if not, if it was documented, why we deviated from protocol? Were the procedures, medications, dosages, standard of care, everything that we did, was it correct? Was it down the right path? Was the exam assessment and vitals documented, and does it match? Destination, was the destination appropriate? You're going to see as we go through this, we've got a lot of questions about destinations, and I'll hit further on that stuff as well. And then was it the adequate documentation for what we're looking for? So with everything you guys seen so far, and like I said, feel free to jump in and say it on here or talk amongst your group. But what are the QA, QI issues that you guys see within this report, within this incident? And I'll put my findings up here in just a second. So, and once again, with all this stuff, don't think that this wasn't a well-run call or a well-maintained call. Once again, we're looking at this at 100% lens. So it's just the questions and the different things we see within documentation. It's going to be extremely hard to always get 100% documentation on an incident, 100% standard of care on an incident, but that's what we strive to go for, and that's why we're doing this. So a couple of things that we kind of saw when we looked at this is we had very little pertinent negatives on this. So when I talk about that, and it kind of goes into the second one here too, is no documentation of a true trauma assessment. It looks like we're possibly going down the route of more of a trauma arrest on this one. So doing that head-to-toe trauma assessment and documenting your findings on that and any pertinent negatives will be tremendously important on this one. So making sure that when we have those, we're doing that and documenting our findings. Some people would say, well, yeah, we did that within the flow chart, but those things are important to add if they're significant to your incident and to your narrative. And if it's significant to your incident, which it would be in this case, it needs to be mentioned within the narrative. For instance, back in the flow chart, we documented diminished lung sounds. Well, initially you should have had no breath sounds if they were pulseless and apneic. So making sure that those areas actually match up, because that area should have been your initial exam and assessment of the patient. So they shouldn't have been necessarily diminished at the very beginning. If they were, they would have been still breathing. So just different things to understand about the different areas that we document within our PCR. The EKG rhythm documented one time, or actually twice, because we say PEA and then asystole, but we didn't document any changes in the middle. So for instance, if we started off with PEA, and we started CPR, then we gave some drugs, coming back in your narrative again and saying they're still in PEA, or they converted to asystole, or they converted to VFib, making sure that we're kind of documenting that out within our narrative of how it looked, not just they maintained asystole the entire time, which kind of contradicts what you had the first time, which was PEA. The other thing we don't really talk about is, did we initially put them on the monitor using combo pads, or did we go straight to a 3-lead? And when did we do that? Because according to your documentation, we didn't interpret a rhythm until after the IO and ET, because that's when it actually shows that we put them on the life pack. So just little things within there to make sure you've got a good chronological time order within your report. Did we attempt an IV before the IO? If not, why not? We should be at least assessing for an IV before we go to an IO, and we need to make sure we're documenting that. So did we look at ACs and they didn't have anything? The other thing I will urge people to start looking for are EJs before we go straight to an IO. A lot of times, we go straight. A lot of things that we see in reports are we try an AC or look at an AC and we can't get an AC, or we blow an AC, then we just totally forget a line and say, I don't need it, or we go to the other end of the extreme and start drilling somebody. So just make sure we're looking at different options for IV access. Not that we shouldn't be doing IOs. Not a problem on this one. Just make sure we're documenting that we're through that practice of looking for an IV, can't get anything, had no IV access, AC or EJ, so we moved to IO. Had a conversation the other day about auto vents. One thing I didn't understand was evidently Inglewood and I believe Union were a little bit different from Clayton on how we utilize the auto vents and when we utilize the auto vents. And that would be something that we're going to kind of deal with moving forward. But, we posted in this report that we bagged this patient from the minute we intubated them or prior to intubating them all the way through arrival at the hospital. We have auto vents. I kind of look at auto vents just like a Lucas device. They provide the best possible care for your patient. Lucas is doing CPR better than you're going to do it. An auto vent is actually going to ventilate and oxygenate your patient appropriately better than what you can provide because of the absolute settings we can set with that. So the quicker we can get someone on auto vent, does us a couple things. It frees up another person not having to manage an airway, and it also is providing us the appropriate volume and tidal volume and oxygenation and ventilation for that patient. So we're going to talk a little bit more about that as we move forward in this collaborative about different little standard of care issues we may look at changing or bringing together so everything's a little bit more the same between the departments. Treatable causes. We kind of just, we're in a Sicily, so we're doing atropine, epiatropine. Did we look at anything else? Did we think about bicarb? Did we look at those treatable causes? Obviously, we're probably dealing with a traumatic arrest. Or is it traumatic arrest because we're hypovolemic? Are we bleeding out inside? Do we have a bullet to the heart? I mean, there's all kinds of different avenues there, and are we at least documenting that we're looking at those different avenues for H's and T's and treatable causes and doing what we can to overturn those different causes. Documented as a GSW, did we know this? So in another area of the report where it's asking you for your primary impression, one of the things it actually says a GSW, which isn't a bad thing. If we knew it was a GSW, that's one thing, but just be leery because in your narrative you do it as a penetrating wound, which is fine. But if you're documenting that two different ways in your report, this is one of those that a defense attorney or prosecuting attorney or whatever could come up to you and say, well, how do you know that's a gunshot wound? Did someone tell you it was? How do you know that that's a gunshot wound, but this one is some other type of wound? So just be leery about documenting gunshot wounds like that unless you absolutely know that it's a gunshot wound. Timeline documentation. So in that narrative, once again, a decently written narrative, but like towards the end, we put patient given 4 epis, 3 atropines per protocol. If we can do that more in a timeline, especially if we have change in rhythms. If we had a patient that went from PEA to a Sicily to VFib to back to a Sicily and then to VTAC and then back to a sinus rhythm, it's going to be real important time frame wise that we're documenting how and what procedures and medications we're doing as we go along, because we need to make sure that those procedures, those drugs match up with the different variations of interpretations, EKG interpretations. So just understand that about your narratives and understand that your pertinent information, even if it's documented within your flow chart or that procedure area, the pertinent stuff, according to that call, depending on that call, also needs to be documented within your narrative. We talked a little bit about on-scene time or overall time on this call as well, is that we had a 55-minute from on-scene to at-hospital time. This is a little bit expanded, but understandable. This is another one of those, are we going to stay, work them on the scene and possibly terminate them on the scene if we don't get any change? Or is this one that we're just going to kind of pick up and go with this one? This was an 18-year-old, still, I think they documented still warm to the touch. So they determined to scoop and start moving. We did spend a little bit of time on the scene, but just try to shrink down that time as much as possible, especially when we're dealing with trauma cases. Quicker we can get them to a trauma center, better off we're going to be. And the last thing I'll talk about on this one is just what I call crime documentation. Anytime you have any type of incident that we're on that is dealing with any type of criminal act, specifically criminal acts, be very diligent about your what we're reporting, how we're reporting, and how we're documenting. So, for instance, we documented the body as a female found outside of a building face down. And that's the only kind of description we give of the scene. The only real description we give of the body is pretty much one penetrating wound to a shoulder. the more we can expand on that, the better off it's going to be for you, because with this one, if this is a homicide case, you could be called in 6 months later, 2 years later, 5 years later, 10 years later to recall this call. So the more that you can document to bring that stuff back up to you, the better off you're going to be. Position of the body, anything odd, what they were wearing, what was she wearing? No pants, was, all that stuff plays into this. Just think about that, about crime documentation. So before we move on to the next one, does anybody have any questions or comments on this one? Okay. So the second one, Medic 85 on a fall, and this was an 89-year-old female. So for those of you that aren't familiar with ERS, this is just very similar to the assessment and flow chart area of ESO. So initially we look at the initial assessment vital, the first set of vitals in the exam, and some of the things we see here are primary symptom and impression we're documenting as repeated falls and an injury to the head. We're a little hypertensive. And the other thing I picked out on this is we got a laceration with pain to the head in our assessment. So once again, what am I thinking here? Some of the things I'm thinking, if I go through and look at what else is documented in this call, the only other thing that's documented in this call is another set of vitals, and I still see that they're hypertensive. They do have a GCS of 15 in their alert. So the questions that I have on this one are, okay, so are we dealing with a trauma with a fall? They're 89 years old, so trauma criteria switches up a little bit there for the geriatric patient. Repeated falls is documented, so kind of if this is repeated falls, by repeated falls do we mean many times in a week, in a month, that day? And then why are we having repeated falls? Why, if we documented that, that should be a new thing, so why are they falling? And then do we have a head injury? Because we are documenting injury to the head, and they are also hypertensive. So there's a couple of questions I have. I hope to have those answered through the rest of the documentation. Give me 1 second here. So the narrative, Medic 85 was dispatched to the above address for an 89-year-old female who was experiencing a fall. Upon arrival, patient was found laying supine on the floor at the foot of her bed in her room. Patient's nurse was holding a gauze with direct pressure to a small bleeding laceration on the posterior right side of the patient's head. The bleeding from the laceration was controlled. The facility stated that the patient fell while trying to get out of bed and go to the restroom. The facility staff also stated that the patient's fall was not witnessed by the staff and that the patient was found approximately 15 minutes after the fall occurred. The patient stated that she hit her head on the dresser when she fell. The patient denied experiencing any LOC. The patient denied experiencing any nausea, vomiting, or dizziness before, after, or during the event. And the patient stated that she has pain in her head where the laceration is present, and the pain is a 5 out of 10 on a numeric scale. The patient denied having any pain elsewhere. Upon full visualization exam, the only obvious injury found was the laceration to the posterior side of the patient's head. The patient had been previously diagnosed with dementia. The patient's nurse stated that the patient was in her normal mental state. EMS immediately held C-spine and placed a C-collar around the patient's neck. Patient's pupils were bilaterally equal and were able to follow ocular commands. The patient stated that she had partial blindness in her left eye. The patient was carefully log rolled while maintaining C-spine onto a sheet and was lifted by EMS onto the cot. Patient was secured to the EMS cot via straps and rails. The patient's nurse stated that the patient was on blood thinners as well as other blood pressure medications for hypertension. The patient was placed into the medic without incident and her vitals were obtained. The Patient's vitals were listed in the report. Patient was transported to Miami Valley North and assigned to room 7. Patient was given to the nurse, and the patient was left in the care of the ER staff. Okay, so same questions as before, and we're asking on every single call. So with this one, once again, feel free to jump in if you see anything, and I'll bring up mine here in a second or talk within your group. So right off the bat, I mean, I think this was a well-written report. I still go back to you documented repeated falls, and we don't say anything about repeated falls in the report, and you know why they're having repeated falls. Is this an ongoing issue for the day? Or is it a balance issue? Is it a trip hazard issue? Those kind of should be playing into your assessment of the patient. So that's one thing that we should be documenting. Another thing that we see, we've seen as a trend moving through the last couple of years with this QA/QI process, and I'm not saying this call should have been ALS, but it's something to think about with this call. It's the whole ALS versus BLS question of should this have been taken BLS or ALS. There's a couple things I'll throw in there is that this patient's on blood pressure medication and they're still hypertensive and maintained hypertension throughout the event. We never put them on an EKG, and I go back to those repeated falls again. Are we falling because we get weak and fall? Is there a blood pressure issue? There's all kinds of issues there that as an ALS provider, we can look further into over a BLS provider. Pain control, once again, this isn't that big of a deal. You know, a 5 out of 10 for a laceration. You may just have an 89-year-old lady that has some pain from a laceration. That's fine. I'm not saying we have to follow a pain control protocol or give them fentanyl for that. I'm just saying there are different things to think of with this call that when we see someone experiencing pain of a 5 out of a 10 scale, I know that's really subjective, but it's things that go through our head when we're looking through that 100% lens again. And then the last thing on this one is, again, transport decision. One of the things we struggle with a lot in the QA/QI side of things, and even on the administrative side of things in the departments, are the hospital that's in our jurisdiction. It's awesome having a hospital in our jurisdiction. It's also a big hindrance when it comes to these type of issues. This person, per protocol or per trauma criteria, should have been considered for a trauma center due to age, due to blood thinners, due to possibility of head injury. But we don't document anything about that within the call. If that patient adamantly refused to go to a trauma center and wanted to go to Miami Valley North, that's fine. That's their decision. We just need to make sure we're documenting that a little bit better in those calls. We need to make sure that we're doing our due diligence and being a patient advocate and making sure that they know that the hospital they're going to may not be able to fully care for them in an appropriate manner, and that they may be transferred out of that facility, and we may be delaying definitive care to that patient. And you'll see that a couple times on these as we go through there, that transport decision, mainly with Miami Valley North, becomes a factor a lot of times. We see a lot of times that we're going to North because of the closeness of the facility. Just because it's close doesn't mean it's the right facility, depending on the patient condition. So make sure that we're being diligent about that and understanding what North can and can't handle. And I understand that that's also kind of a flowing thing at North, but truly the easiest way to think about North is if those individuals are going to be admitted and need an ICU, they don't need to go there. If they need any type of specialty care, they don't need to go there. And if they're demanding to go there, then we just need to make sure we're doing a little bit better job explaining that out within our narratives of why that decision was made. Questions on that one? Number 3, this was Medic 98 for an illness. This was at 1937 hours. It was an 84-year-old female. So again, looking at the assessment of this patient, some of the things I see right off the bat is we're confused. We had facial droop with a mass and swelling. We have clear breath sounds, but we also have facial droop and slurred speech. So a couple things pop out at you there of what we're anticipating seeing in this report. And then as we look at the vitals, one of the things that pops out to me first is we're only alert to verbal stimuli. So we have a little bit of diminished level of consciousness there. We've got some hypertension going on. We've got a blood sugar of 90. So it's, again, we can kind of have a rule out there of what we're dealing with. So again, some of the things, thinking to myself, what should I see from here on this call? When we go back and we're looking at what we've got here, possibly dealing with a CVA, but understand that there's a lot of different things we have to look at if we think we're dealing with a CVA. There's other rule outs that have to occur there. We have to be kind of detectives. So when I look at the flow chart on this call, looks like we did a 12 lead. Looks like we had an unsuccessful IV and a successful IV, and then that we call a stroke alert. So questions I have is, okay, if it's a stroke alert, do we follow the CVA protocol? And then what's the history of this? Are they diabetic? Is it a CVA? Is it sepsis? Are we doing rule outs? Is it trauma? And they're hypertensive as well. So once again, how is everything going to look in this report? Those are the questions I have right now going into the narrative. So Medic 98 was dispatched to an extended care facility for a lethargic female with previous head injury. EMS arrives to find a female patient seated in a wheelchair. Patient is conscious but not alert. Patient chief complained of possible stroke. Staff states that patient was admitted to this location 1 week ago for a previous fall and head bleed. Staff states patient fell approximately 10 to 15 minutes ago and has not been acting right since. Patient fell out of chair and hit her left side of her head on the floor. Patient was last seen normal at 1700 hours. Staff states patient has dementia, but baseline mental status is able to communicate normal and clearly. Staff states that the patient's speech appears to be slurred, slurred more so than usual. Staff also states that patient was left with no known deficits from previous stroke. Staff denies LOC on the fall, denies anticoagulant use. Patient fails all criteria for Cincinnati stroke scale on scene. A patient is assisted from wheelchair, placed on cot, and loaded into medic for further evaluation and transport. Patient is alert and oriented ×1, negative to place time and event. GCS of 14, pearl at 3 millimeters. Skin is pink, warm, and dry. Blood sugar noted above. Patient is hypertensive, all their vitals stable. Patient is very lethargic and will close eyes unless being stimulated. Patient appears to have trouble keeping right eye open. Patient has a strong, regular radial pulse. Speech is severely slurred. Patient has left-sided facial droop. Patient unable to follow commands and perform arm drift test and grip test. Patient responds to EMS questioning but is confused and unable to appropriately answer questions. Patient denies headache and dizziness. Patient has moderate swelling to the lateral side of the left eye. No external bleeding noted. Blood is noted in the left eye. No palpable injury to C-spine. Patient appears to have no difficulty ventilating. Patient has equal chest rise and fall. Abdomen is soft in all regions. No abnormality noted. No apparent edema noted. 12-lead AKG shows sinus tach. No evidence of MI noted. IV access established ×2 attempted. Verbal report and stroke alert activated en route to ER. Patient transported without change. Transport patient at Miami Valley Hospital, room 2. So same questions again on this one, and I'll let you guys talk about any QA, QI components you see.
Andy,
Yes.
go back one slide, would you?
You want the narrative up?
Yeah.
Yeah.
So that's listed as fails all criteria for Cincinnati stroke scale on scene.
Correct.
But it listed that they have all the symptoms, so I'm assuming by failed.
They had a positive Cincinnati stroke scales test.
Yeah, so should that be documented as positive?
I would say the wording's a little bit hokey there, and they could probably change positive and negative verbiage is probably better there, that they were positive for all Cincinnati stroke scale versus exactly what they said there again, but fails all criteria, so they failed all those tests. I think it's just a verbiage issue there. I don't know if that's a big deal today, but yeah, I can see confusion there as well.
Yeah.
So some of the things that we found is I go back to making sure that the things that are pertinent to your call are listed in your narrative. So we do blood glucose noted as above. Okay, and above it's 90, and that was in your flow chart or your procedure area, and that's fine, but it's that's significant to your event here. So make sure you're just blood sugar was checked and that's 90 versus noted above. That way everything flows within your narrative and you're telling more of a story that, yep, blood sugar was checked, no significant findings. It was within normal limits. So make sure stuff like that gets actually put into your narrative. Assessment tab and narrative have some matching situations. When we put no abnormalities on, different areas of that assessment, but then we say something different in the narrative. Your different areas of your procedure area, your flow chart area, all those things need to match with what's in the narrative. If not, that can come into question about, but you documented it this way here and this way here, so which one was it? So just make sure you've got matching narratives and assessment in vital areas. Flow chart, the same thing I just said. Stroke alert versus trauma alert. That's probably the biggest thing on this one, and this is a confusing one because they are showing all signs of a stroke. We've had a previous stroke, but the other thing is this is a quick onset after a traumatic incident. So we were fine prior to falling out and whacking our melon on the floor, but after that is when immediately we started experiencing symptoms. So we go back to protocol again and look at trauma protocol and that geriatric patient that had that standing level height fall with GCS of less than 15 with signs and symptoms of traumatic brain injury should be going to a trauma center with a trauma alert. So it's one of those things of being able to be a detective and see those rule outs to see exactly where we're going. So this is why we do blood sugar checks on stroke patients. This is why we do 12 leads on stroke patients. This is why we make sure that if it was a traumatic event associated with this, we're ruling out trauma versus stroke. So this definitely should have been a trauma alert over a stroke alert. But the one thing I will say is we did go to a trauma facility, which is a good thing on this one. Well, along with that whole thing, it should also have been full spinal immobilization on this patient per trauma protocol for that exact reason is we have someone fell, struck their head, now they have a diminished level of consciousness, so they should get fully immobilized and taken to a trauma center. Another good one on this one is that we forget about a lot of times is one of our assessment tools of capnography. We do very good utilizing capnography on what I will call our respiratory calls, our COPDers, our CHFers, intubated patients, even asthmatics. But we don't necessarily use it on everyday other run-of-the-mill calls. And this would have been a good one to have a little bit more understanding, give you a little bit more understanding of their neurovascular compromise in this patient. It also gives you an idea by looking at their respirations, by looking at their capnography, by looking at their waveform, Biot's respirations, Cheyne-Stokes respirations. All those different patterns can help lead you and help you investigate. It goes back to the stroke versus trauma alert as well. So just always think about that capnography use as well. It's an easy tool that we have, and it can give you a tremendous amount of information. Questions on this one? Number 4, 1552 hours, 51-year-old female, motor vehicle crash, Medic 85, Ladder 85, and a bunch of other crews. So this is a bit of a long one here, but we'll get through it. So initial assessment, some of the things that pop out right off the bat is we're dealing with an unconscious patient with a traumatic injury from an MVA. There's abnormalities in the breathing for a primary symptom, and primary impression there's multiple injuries. In the exam, we're showing that they're unresponsive, that they're pale, that they're bleeding from some type of a controlled bleeding from some type of a puncture wound or contusion. That pupils are sluggish or non-reactive. Breath sounds are decreased on both sides. We're hypotensive. We're tachycardic. Respirations are agonal and weak. And then we got GCS of 3. So that tells us a lot. We got a lot documented there. Paints you a pretty good picture of how screwed up this patient is. So once again, what are the things I should see in this as we're going further? Well, I've got a lot of things I should see on this. Once again, anything trauma related, airway issue on this one, big time. GCS of 3, agonal respirations, diminished breath sounds, a lot of factors there. So, obviously I'm going to be looking at airway stuff and we're looking at trauma stuff right off the bat from what I see. Then I go into this procedures section and start looking down through the procedures and see what we did for this patient. Another airway assessment there looks, once again, agonal respirations, airway complications from injury or trauma. So clenched jaw, see a lot of good things there. When it comes to the airway, good evaluation of the airway. We put on a collar. We fully immobilize the patient. We assisted ventilations with a back valve mask. Gave him oxygen. Looks like we'd had a successful line. Gave him some fluid. Did a 3-lead. Did another successful line. Have another set of vitals, or I think this is actually the first set of vitals from the first page. But we're still tachycardic, hypotensive, unresponsive, GCS of 3. Did 12 lead. We suctioned the airway. We did an oral intubation that was unsuccessful. We gave etomidate, 20 milligrams. Did another oral intubation that was unsuccessful. Contacted medical control. So we got another set of vitals here that we said we were unable to get a blood pressure, but we're still tachycardic, still got crap agonal respiration, still unresponsive, still GCS of 3. Did a successful surgical crike. Assisted ventilations again, capnography. We did a needle decompression. Can't see what the top one is there, but something was successful. Blood pressure again, and then I kind of question that where we go from hypotensive to extremely hypertensive with narrowed pulse pressures. I question that BP is accurate. Question that, but it could be. It could be. Got a decrease in the pulse, the heart rate. And obviously we're breathing for the patient now with a capnography reading of 25. Another set of vitals where we've dropped in the heart rate again and unable to get a BP. Contacting medical control again. So questions I have right now, just off of what I've read, is airway. Airway assessment looked like it was a good airway assessment. Procedures, and we had a couple failed airway attempts. So why did we have those failed airway attempts? And then obviously we did a surgical crike that was successful. So definitely want to see something about that and read into that a little bit more. Trauma protocol. This would be a good one to make sure we followed all the trauma protocol. Shock. Obviously, we're seeing just from the vitals and everything, we've got a patient in shock, and we're seeing trends in those shocks, in that shock, but BP, not having BPs kind of hinder that, so being able to have that documented in our call. And then times. I want to look at times on this one too with dealing with a trauma patient. How long were we on the scene? How long was our transport time? Did we have any delay of getting them to a surgical center or a trauma facility? Okay, so crews dispatched on on a MVA, 2-vehicle MVA with multiple injuries. Call was dispatched as a trap. Car 1 first on scene and reports 2 to 3 car MVA with heavy damage. Medic 84 second on scene and assigned to triage all patients and assume triage officer duties for this incident. Medic 84 crew made the triage efforts, including triage ribbons placement, before additional chief officers arrived on scene, and Medic 84 was assigned to furnish patient care to the driver of the Cadillac sedan. During a brief survey of the scene, the vehicle damage, Medic 84 crew noted very heavy passenger side impact, including significant intrusion involving this patient's vehicle. It was also noted that the front seat passenger in the Cadillac was pulseless and apneic. A third passenger was noted in the back seat of the vehicle. It is not apparent if any occupants were restrained, but airbag deployment was noted. Crews on scene were able to carefully and quickly extricate this patient from the driver's seat to a backboard for seat collar placement and full spinal immobilization. During a rapid initial exam, it is noted patient has a GCS of 3, patient's eyes open but sluggish or non-reactive. Patient unresponsive to all stimuli. Radial and carotid pulses noted. A small puncture wound noted above patient's right eye. Open compound fracture noted to the patient's right femur. Patient rests are weak and slow and shallow. While fully immobilized, patient moves to EMS cot rails raised, straps fastened. Patient moved to Medic 84 by EMS crew without incident. Patient vitals taken and noted into this report. Only one reliable BP taken and noted, but patient remains with carotid pulses during EMS care. Patient's clothes were removed for detailed physical exam, while bilateral AC IV access was gained, both with 18-gauge IV catheters, while another crew member was providing high-flow O2 via BVM ventilations. Patient's oral airway was suctioned of blood and assessed for intubation, but crew member reports that patient's jaw was clenched. Patient cause for an intubation efforts abandoned. Patient given 20 milligrams of etomidate as BVM ventilations continued and intubation efforts reevaluated. Failed intubation attempts as crew members reports obstruction in the patient's airway assumed due to injury sustained in the MVA. Patient's cricothyroid membrane was then assessed and surgical cric successfully performed. Cric tube placed, noted with present lung sounds, condensation in the tube, and an adequate waveform and numeric capnography noted between 27 and 45 during the remainder of EMS care. Cric tube secured and crew continued BVM ventilations on high flow O2. Cric tube was suctioned once due to moderate amounts of blood in the tube. Patient then decompensated decompressed on the right side of the midclavicular, midclavicular between second and third intercostal space due to diminished lung sounds during auscultation. Airflow noted after chest decompression during a detailed physical exam. No further findings noted, and patient's GCS remains 3 as carotid pulses noted. 3 lead obtained and results in sinus tach during EMS care. 12 lead shows no ST elevation or other remarkable cardiac findings. Initially, patient was given 250 milliliter bolus of saline during transport to maintain an adequate blood pressure. Medical control was contacted during transport, once to advise them of the condition and a trauma alert, and second to update medical control of a surgical cric airway. Patient's GCS remains 3, and pulse is noted for the duration of the EMS patient care, taken in the supine position with fully immobilized to MVH-ED. So, anything, questions, concerns, comments on that one before I throw some stuff up here? So good documentation, thorough documentation. There's some things missing, but for the most part, very, very in-depth, good documentation. Great job on the airway. Once again, it's if we can't get someone intubated orally, that's not a problem. We just need to document why we can't get them intubated. That was a good one. You know, first one was jaw was clenched. We gave them etomidate, and we got in there and they had damage to the airway. So they said, screw it, we're going to surgical crike. Perfect. We documented that all out. Just a couple things to say about that that have been brought up the last couple of days is just remember etomidate's a great tool. And it's a great tool in trauma as well, but understand, especially with head trauma and signs of head trauma, etomidate may actually cause more trismus in your trauma patient, which again isn't that big of an issue. We can bag through that. That's not a huge issue. I'm not telling you not to use etomidate during a trauma. Just understand that you can have that issue with trauma patients with suspected head injuries of having further trismus from the etomidate. Documentation, further trauma assessment, documenting further trauma assessment findings and ongoing assessment. So we document that we did that, but one thing that we document that we did find that we never really did anything or addressed, which actually could be considered a life threat, is that compound femur fracture. So we never really readdressed that. Did we do anything with it? Did we splint it? Did we check pulses? Did we check for internal bleeding, external bleeding? We really don't mention much about that other than it was there on that initial trauma assessment. So just one thing to realize with standard of care issues and with documentation is make sure, especially something like that, that could be a life-threatening injury, that we're doing something about that. Go back to the vitals issue again, is this would have been one of those patients of every 5 minutes they're unstable. Every 5 minutes we should have a complete set of vitals, if at all possible. One things we really don't talk about is we get one blood pressure, truly one viable blood pressure on this patient that's hypotensive. It would have been really nice to be able to see that we're maintaining that pressure of 90 or 100 all the way through, which we kind of do document, but they did have a carotid, and a couple times in there we said they had a radial. But be able to document if they're compensating, decompensating through that process. Why couldn't we get a blood pressure? Was it a monitor issue? Was it an arm issue? Could we have switched arms? Could we have gone to a leg? Whatever it may be, just realize that too. Blood pressure in this patient becomes extremely important. Do we do anything for the compound fracture, which we already talked about? The only other thing I'll talk about is just making sure, like I've said before, there's pertinent findings, making sure that we're putting those into our narrative as well. There was another thing on here that I think vitals were taken and noted above. Well, significant finding is those vitals of a heart rate of 130 that continues to drop all the way through your transport. And once again, if we would have had significant blood pressures there, we could have seen that trending of compensating, decompensating, and further. So, but overall, once again, just like these other ones, these aren't necessarily horrible calls. We're always going to find things wrong with certain calls. I don't expect you to be 100%, but it's always that striving aspect here. This was another good call, and crew did a very good job with an airway. There's very few people that can say that they've done surgical crikes, and this was a successful one that seems like I had very, very little problems with. Questions, comments, concerns on that one? So the next one, 6:37 hours, medic 98 for cardiac arrest, and it's not a 669-year-old female, but I believe it was a 69-year-old female. So on this one, can't see what the mental status is on this one, but I think it's unresponsive. compromised airway. On your airway assessment, we're showing Rales bilaterally and presence or decreased respirations with treatment of hypoglycemia. So what I'm kind of confused what we're dealing with right off the bat here, but maybe a diabetic. As I look at the vitals, we're alert to painful stimuli only. Again, later on this call, we're still a little hypertensive. We're showing a blood sugar of 39. We've got no pulse ox and no capnography documented. So I got a couple questions there. Once again, what should I see? I'm really not sure what we're dealing with yet, other than we got a compromised airway. So obviously I should see something done with the airway, and we're possibly hypoglycemic. We are hypoglycemic, and we're hypertensive. So a couple questions there, make sure we're hitting different things. So what did we do? We bagged the patient right off the bat, it looks like. Did an unsuccessful IV, did 12 lead, another 12 lead, we did an IO, then we gave D10, and then we gave oxygen on non-rebreather. So poses a couple more questions to me there. In this timeline of we bagged somebody, couldn't get an IV, it looks like. Then we drilled somebody and gave someone D10. So it looks like we were dealing with a diabetic. So obviously I've got a couple questions there of they were unresponsive. Did we do a good investigation of why they were unresponsive? They got a compromised airway, that they had Rales, they needed suctioned, but we did bag them, it looks like. So looking at the airway issue on this one, they're hypertensive, the hypoglycemic, and the IO I've got questions on. So let's go forward and see what we can find. So chief complaint of hyperglycemia. Nursing home staff requests EMS reporting a cardiac arrest. On arrival, crew informed that patient was at no point pulseless or apneic. Patient was recently tested for COVID-19 following exposure. Test was negative. Nursing home staff has no further information. Patient found in bed unresponsive. Patient being suctioned by nursing home staff who states she was foaming at the mouth. Rales present throughout. Patient's rest present as shallow at approximately 20 breaths per minute, unassisted. Skin color is normal. Condition temp normal. Radial pulse is regular. No further abnormalities found during physical assessment. Patient's respirations assisted using BVM. Time with patient's respirations. Patient responsiveness increased with assisted ventilations. 18 gauge attempted, guessing with no success. Patient withdrew from insertion catheter, causing withdrawal of the catheter and failure of attempt. Patient has a notification bracelet that no IV or BP be taken on the right side, with left side being compromised, right side being inaccessible. Patient remaining mildly responsive in conjunction with presentation appearing to be respiratory in nature prior to blood glucose being obtained. And IO was utilized for access, IO insertion into the left humeral head, aspiration from marrow withdrawn, then IO secured. D10 admin via IO at wide open. Assisted with pressure infusion, patient's respirations and airway patency improved dramatically within minutes. BVM discontinued and placed with O2 delivery via non-rebreather. Patient became increasingly responsive during transport, leading patient to become alert to activity around her as evidence of a return of spontaneous eye movement. Patient remained unable to produce words further than groaning, but improved in regards to reaching for treatment delivery methods such as O2 tubing and IO. Patient lifted onto cot with blanket lift, secured straps. Patient transported to Miami Valley North due to proximity without further changes in signs and symptoms. transport delayed due to attempt at collecting valid DNR as patient's paperwork states existed. Crew members stated that upon attempting to collect the valid DNR, the staff refused to retrieve the DNR. When explained the importance of the document and asked once more to retrieve it, the staff maintained their refusal to present the patient's DNR, stating that the patient they requested EMS for to an initially reported cardiac arrest who was found unresponsive with a listed history of dysphagia and verbally retracted the DNR. Crew returned to the ambulance and commenced treatment. So this is just the 12 lead with the report. Nothing truly significant there. No ST elevation. So same thing there. We can anything anybody wants to say, or they can talk amongst their group, and I'll throw my stuff up here in a second. A couple things: well-written narrative, in depth, very well written. Good immediate assistance with the BVM. Once again, we were quick to assess the airway and realize that they weren't ventilating or oxygenating appropriately, so we needed to assist with that. Perfect. But let's talk about the IO for a minute. This is where I go into your pertinent negatives and truly making sure that we're assessing the patient appropriately. We can manage the airway while we're trying to do other things and really figure out what's going on with the patient. A lot of times we'll read in calls, and we saw one earlier, we honed in on a stroke, the stroke path, and we didn't investigate everything. This one, I think we kind of honed in on the respiratory tract, and we didn't investigate everything. So just understand that IVs, we should be looking for IVs first, and we did on this one. But once again, we looked at an AC and we blew it. We compromised that arm, and we kind of just went straight to an IIO. Remember EJs. I think EJs, I don't want to say they're a lost art, but EJs are great veins. And so they're great veins for unstable patients. They're great veins for arrest patients. They're good veins. They're just like any other vein in the body, and they're a big one, and they're good, and you normally have good access to them. And if you assessed it for an EJ, make sure we documented that we assessed for an EJ before we move to something else. So understand that IOs should be reserved for those incidents where we have no other vascular access, and we have a patient that is hemodynamically unstable. I'm not trying to point people away here from doing IOs on semi-conscious patients. Nope, absolutely we can do those, but we should make sure we're exhausting all those other avenues for IVs. Along with that, make sure we're going down all routes, and before we go and do something, make sure we're making sure that this is a respiratory route and not a blood sugar route or a hypoglycemia route. Also remember, when we're doing IOs for semi-conscious patients, before we go flowing any fluid or medication through those, a lidocaine's a good option there. We should be giving lidocaine. I'm sure, I kind of laughed when I read this one because I'm sure she became much more responsive because I'm sure she was in a little bit of pain from all that fluid that a D10 that we were jamming into her bone marrow. So lidocaine's a good option there for us. Don't forget about that. Blood sugars, we talked about capnography earlier being a good assessment tool. Blood sugars need to be a higher priority a lot of times for these unresponsive patients to check early so we don't wind up in this situation, because we do have a much easier method here other than an IO, and it would have been glucagon that we could have given this patient. Yeah, it takes a little bit with the absorption route, but glucagon would have been a much better option for this patient. Just reversible causes for reduced consciousness. Make sure we're looking at pupils. Once again, being that investigator, checking sugar, checking pupils. Was this an overdose? Could we have been dealing with some type of an overdose? So just different things there. Understand that we've got different routes to look at before we jump right down one rabbit hole of a respiratory. And once again, it happens. We've all done it. We'll continue to see it, but it's just one of those things of make sure we're investigating everything and doing those rule outs of different factors. Anything on this one? Here's just a reminder of the protocol for IOs. That's what I just stated a minute ago. Hemodynamically unresponsive patients after we've exhausted IV. Okay, number 6, 43-year-old female, medic 85 for a diabetic, 1912 hours. So look at this one, and we have primary complaint diabetic. They're weak and hypoglycemic, primary impression. We're confused. We're diaphoretic and clammy. Got blood sugar of 42 and GCS of 15. So right off the bat here on this one, okay, so we're going down diabetic route, and it looks like we got a sugar of 42. Okay. But one thing we see a lot of is GCS. So this GCS is scored at 15. Very well could be, but anytime I see mental status is confused, I question a GCS of 15 because if they're confused, are they oriented? So just once again, making sure the different areas of a report match up with what we're saying is something to remember there. So different things I should be looking for, once again, diabetic protocol, looking down that route, making sure, once again, that we have other rule outs as well. So as I look down the path here of our treatment, looks like we did oral glucose, and then 5 minutes later did another tube of oral glucose. Looks like we had a successful IV after that. And then we gave D10, and then we had another set of vitals, which look okay with a blood sugar of 76. So why am my questions on this one right off the bat I see is why oral glucose? Yes, I understand we carry oral glucose, but we are also ALS providers. And I've got questions of that. So explaining why we're using oral glucose versus the other couple of routes that we have for a hypoglycemic patient. So chief complaint on this one's a diabetic. On arrival, patient sitting in a seat on blood pressure machine in Walmart. Staff states that she sat down there and started yelling for help. When family arrived, they stated she is a known diabetic. Patient given 2 oral glucose packs with no improvement. Patient then assisted to cot, strapped in times 3 with 5-point harness. Patient removal made to Maya Valley North. Patient alert to only verbal stimuli. Once a medic, 18 gauge, D10 started. On patient after 100 milliliters given, patient began to respond to crew. Blood sugar checked, reading 72, 50 milliliters more given before crew arrived at ER. Patient's blood sugar now 76. Patient's vitals remained within normal limits. Transported, patient now alert and oriented times 4. Vitals times 2, 2 oral glucose packets, 18 gauge, 150 milliliters D10. Semifailures position, status improved, report to RN, room 14, transfer without incident. So questions, comments, concerns on this one? Once again, feel free to talk there for a minute and I'll throw this stuff up. This one's pretty cut and dry call. It looked like a simple hypoglycemic patient. But once again, I go back into the rule out things again is they're diabetic. I understand that, but you know, are we ruling out there's pertinent negatives that we don't document in there? Ruling out other things. Could they have been septic? Could they have been this? Once again, not everything needs to be spelled out fully in a report that yes, we checked this, and this, but pertinent negatives should be listed to down through this call. I question when you look at the times on this is why we gave oral glucose, and not only why we gave oral glucose, but why we did 2 tubes of oral glucose. Once again, I know it's there as a tool for us to use, but we have better, quicker, easier ALS tools to use as ALS providers. Why, if you got dispatched, I don't know. According to your report, you got dispatched on diabetic, so why didn't we check that blood sugar first off? Because according to your documentation, we gave 2 tubes of oral glucose before we checked the initial blood sugar. So check your initial blood sugar. If it was 42 and we gave, to get sugar up to a normal level with oral glucose, you're going to be there for an hour trying to get their sugar up with oral glucose. So there's no reason why we can't start a line, do D10. If they want to refuse, they can refuse. Or we start a line, do D10. If we can't get a line, we do glucagon. So just a couple things there with this one. A little bit better documentation of pertinent negatives, and then again, the oral glucose factor of or do 1 tube, 2 tubes, and then they go unresponsive and almost unresponsive. I can't remember exactly what the wordage was, but alert only to verbal stimuli. So we had a change in level of consciousness, and that's when we start a line and do D10. So a couple things to think about on that one. Questions, comments, concerns on that one? Number 7, 5:13 hours, the fall for Medic 99. It was an 88-year-old male. So on this one, as I'm going down through, looking at the assessment stuff, pretty unremarkable. They're oriented. Nothing particular with the airway. We got some weakness within the extremities, all extremities, arms and legs. But other than that, that's about all we're showing on here. Look at the vitals, and I see maybe a little bit hypertensive, and we got a blood sugar noted at 93. So nothing really significant pops out other than we know that we're dealing with a fall with an 88-year-old male. So when I'm thinking about stuff, once again, if it's a fall with a geriatric patient, I should start seeing something to make sure we're following trauma protocol in this. When I look for treatments or further vitals, when I try to see any further treatments on this patient, we don't have anything documented in the flow chart. So what are we dealing with this one? Well, pretty much right now, all we know is we got an 88-year-old male. That was a fall. Really don't know what the injury is, if any, or why they fell. And so once again, going back and trying to thinking about that documentation, things I want to look for is that, and then whether or not we follow trauma protocol. So chief complaint, patient has hip pain from a fall. Patient was up trying to use the restroom and fell on the tile in his restroom on his arm and hip. Patient has diabetes. Patient was alert and orient ×4 upon EMS arrival with a GCS of 15. Patient was laying down on the ground upon EMS arrival as well. Patient's pupils were pearl. Patient denied head, neck, back, chest, and abdomen pain. Patient lung sounds were clear bilaterally. Patient was able to speak in full sentences and denied trouble breathing. Patient's abdomen was soft and non-tender. Patient had a shooting pain upon moving his left hip from the fall. Once patient was on cot, patient had no pain. When extending his leg, they were both the same length. Patient had a small contusion on his left arm from the fall. No other deformities or contusions were noted. All necessary PPE was used for EMS and the patient had no fever, cough, or shortness of breath. Patient was assisted up onto his feet and moved over to the cot. Patient's vitals were obtained in the medic. Patient's family decided to have him transported to Miami Valley North. Patient was secured with seat belts and railings up upon transport. Patient care was transferred to the ED staff. So on this one, what do you guys have? Questions, comments, concerns on this one? So a couple things on this one. We truly have a minimal assessment and exam of the hip documented. We're dealing with an 88-year-old. We know they're prevalent to falls. We know they're prevalent to hip, pelvis, femur injuries. We had documented no shortening of the leg. We didn't say anything about rotation, but the ER staff did document shortening and rotation of that left leg upon arrival at the ER. I go back to, we really didn't assess it much. We didn't check for pulses. We didn't rate the individual's pain. We just said he had shooting pain when he stood up on it. Did we bare the area? Did we take off a shoe, take off a sock? Did he have pants on? Were we able to get in and actually palpate that area, look to see if there was any deformities? So not a real good assessment documented of what we did there. The only thing that was documented in the assessment area was just weakness and all limbs. Documented the patient, was any further splinting considered? So, again, anytime we're dealing with, someone has hip pain, did we dislocate it? Did we fracture it? Did we do some of the pelvis? We should always be considering some type of splinting if possible. Do we look at a sheet splint? Do we look at a KD? When they have shooting pain when they stand up, but it goes away when we sit them down, well, part of that is because we partially just splinted it on the cot. So splinting can do a lot for your patients at times. Documented the patient had shooting pain. Was pain protocol considered? A couple things on that. And so pain protocol, but once again, we don't document any type of pain level, so it's kind of hard to understand how much pain they were in, other than it went away when they sat down. If the patient had pain, why did we stand him up and move him to the cot? If we had pain at that point in time, we should have really considered splitting it and moving for him so we didn't further damage or put him through further pain. Consider trauma center. Once again, I'll go back to trauma criteria on these geriatric patients. It's a possible long bone fracture at that point in time. We should be considering that trauma center for that geriatric patient. Transported due to, documented as the closest facility, but in your narrative you state that it was the patient or family choice. Once again, I'll go back to north. Well, make sure your different areas match each other. It either was closest facility or it was their choice to go there. Becomes important in this call because if the patient wanted to go to north, and did we explain to him the possibility of him getting transferred out of there? Did we explain to him the possibility that they may not be able to handle his injuries if he does have any type of orthopedic injury that is going to require any immediate or long-term care? This is one that was transported north that was quickly shot back out downtown because he had a broken femur, broken hip. So better evaluation on the hip. And I'll go back to trauma criteria of where he should be transported to. And again, an ALS versus a BLS call. This is a hip fracture on an 88-year-old male with pain, with shooting pain when he moves. That ends up that should be going to a trauma facility. So different things to consider there when we're talking about protocol and ALS versus BLS. Once again, he's also a little bit hypertensive, but different things to consider on this one. Any questions on this one before we hit the last one? And once again, just a reminder what the trauma criteria is for our geriatric patients. Number 8, 22, 12 hours, breathing problem. Medic 99, that's a 67-year-old male. So as we look at this one, unresponsive, we're showing them cold and pale, showing accessory muscle use with retractions. We got decreased in rails bilaterally. And then we show we don't show anything assessed on neurological. So once again, some of the things there that are screaming out to me is got an airway issue, we're unresponsive. Why are we unresponsive? But at the same time, we don't really do a neurological assessment. So anytime we have that unresponsive patient, you know, the neurological side we should be hitting as well. One side of vitals documented. Kind of look down through here. Pressure's okay. Painful stimuli only. Respirations of 4, and no blood glucose noted. End tidal of 45. So a couple of things bounce out to me there. Once again, it looks like we've got definitely have an airway issue we're going to have to deal with. Why are we unresponsive? Is another thing that jumps out to me. So what did we do for this patient? We suctioned them. We bagged them. We did an unsuccessful intubation. Put them off 3-lead. Unsuccessful IV. Looks like we did a nasal tracheal intubation. That was successful. IV, we got an IV, and we tried another one, and it was unsuccessful, and we did a 12-lead. So again, I look at the questions that I have on this. 67-year-old with respiratory distress. So if we're going down the respiratory route, we do a COPD, CHF, cardiac. You know, what are we dealing with on the respiratory angle? You know, retractions and accessory muscle use may point you in one direction. Failed ET attempt. So, you know, why did we have a failed ET attempt? And then I got a question about a nasal tube. Not that we can't do nasal tubes, but I'm impressed that you got a nasal tube, especially with what we've got to utilize, because I don't think a lot of us have endotrols, which makes nasal tubes easier. And it's still a skill that I think it's a lost art that we need to make sure that we still maintain. But I kind of have a question about that when we have some of the other tools available to us. So questions to be answered as we move forward. Dispatched to above address on an unresponsive person. Upon arrival, found a 67-year-old male lying face down in the bathroom, breathing approximately 4 times a minute. No trauma noted to the head or neck area. Loaded patient on cot and wheeled to medic unit. Began bagging patient at a rate of 10 to 12 times a minute with 15 liters of O2 to prepare for intubation. Patient placed on cardiac monitor. Monitor showed sinus. 12 lead obtained. 12 lead showed no ST elevation or acute MI. Assessment showed patient to be breathing 4 times a minute, labored. A negative on JVD, trachea midline. Chest pain unknown. Drugs and drugs and alcohol unknown. Negative trauma noted. GCS of 7. They're unresponsive. Oral intubation attempted with 7.5 tube without success. IV access attempted once in left AC without success. Nasal intubation attempted with 6.0 tube, successful. Confirmed DT tube placement with auscultation, capnography, lung rise and fall. Ventilated patient at a rate of 10 to 12 times a minute. 15 liters per minute O2. IV access established in the left hand, 12 gauge. Saline lock, monitor patient's vital signs en route to hospital. Vitals improved, patient mental status improving. Transported patient to Maya Valley and placed in room 1 for care. Same thing on this one. QA issues, let me know if you've got anything, or talk amongst yourselves, and I'll bring up what I've got. So just from what we have documented right off the bat here is we have what I would refer to a lot as kind of an unconscious unknown. Why do they face down in their bathroom? Well, we really don't know. I know we document no trauma, but that doesn't mean necessarily they didn't have trauma. We find someone laying on the ground and we don't know why they're there. And we've got airway issues, this, that, or the other. Why is that? We still need to treat that as a trauma. They need to be fully immobilized. So it's a possibility of being a trauma until we can roll that out. So that patient probably should have been fully immobilized. Why did we have the initial intubation attempt fail? Was it, once again, this goes back to documentation of why did that fail? Were they real anterior? Did they have a gag reflex? If they did have a gag reflex, could we have found that out earlier by using an OPA? Did we have an OPA in them? Did we have an NPA in them? So a couple questions there, just making sure we're documenting why we had an unsuccessful intubation attempt. And once again, a lot of this goes back to not only your documentation, it should be in there, but that also helps us to kind of know where we need to go in the future with training. We've got what I would call a very good successful intubation rate here, but I also want to know whether that is a primary first attempt success, secondary attempt, third attempt, and then what are those issues we're having. So if we have a constant issue of people failing to be able to get people that are really anterior, that's probably something we need to practice on and train on a little bit further to help curve and get that better first attempt intubation success. Did we use an OPA? STI in place of nasal intubation. Now I'm guessing because of the flow of what I'm seeing is that we decided to go to a nasal intubation because we had a failed IV attempt at first. I go back to is if we can maintain that person's respirations and oxygenation with a back valve mask and an OPA or an NPA for a short while longer while we're looking at EJ, another IV, or even an IO after we look at a couple other things here, then maybe we should do that to get a more definitive airway in place. Not that a nasal airway isn't definitive. We're securing the airway, which is perfect, but that's going to be one of those that once they get to the hospital, that's going to get switched out, which is fine. Like I said, nasal intubation is still a good skill to have because there's going to be those times where we may have to utilize that. But once again, just making sure we're documenting why we didn't get that, utilizing STI when we can, and having that nasal intubation as a backup, that's fine. Immediate airway maintenance in the home. Something we see a lot of, so we document in this call an assessment of this patient that they're unresponsive, breathing 4 times a minute, agonal respirations in the house. And that we scoop them, we put them on a cot, and we wait to do anything with that airway until we get them in the medic unit. That's how the narrative reads. So with that, 4 times a minute needs to be dealt with now. So that would be one of those that there would be no reason why we can't scoop that patient, get them on a cot, and we'd be bagging them going to the medic. That may happen. I'm just saying that's not the way that read. So more of immediate airway assistance, and make sure we're documenting it that way. PPE, COVID, and aerosol generating procedures. It wasn't documented did we have the appropriate PPE on for the intubation for this patient. You know, we're in the midst of this COVID stuff. Just remember those aerosol generating procedures, we need to make sure that we've got the correct PPE on. Anytime we do an intubation, regardless of COVID, we need to at least make sure that our face area is protected. So we've got respiratory protection, whether that be a mask and shield combo, or N95 or surgical mask and safety glasses for standard intubation. We should be doing that all the time. But with the COVID stuff, we want to make sure that we got the N95 mask on with eye protection and a gown for anybody that's getting that immediate close area around the head. So just make sure that we're following that. I think we've hit that a lot here over the last couple of weeks. I think people are finally starting to understand that. I'll talk about North again. This is another one of those that we have, we see a lot of, is that we think, okay, we've got a critical patient, I got to get to the closest hospital possible, but we need to get to the closest definitive hospital possible. This will be one thing if this patient wasn't intubated and we were having an airway issue and we needed to get them to a closed facility to secure that airway, but we secured that airway. So we've got the immediate problem figured out, handled, go the extra 7 miles down the road to a definitive facility. We've got the immediate thing handled. That patient is going to need an ICU, so they're going to get shipped out. Go to the definitive facility once we have those immediate problems taken care of. You've captured that airway, so there should be no problem to maintain that going to the hospital. And I go back to making sure we're not honing in on just that single path. We honed in on a respiratory path here again. Did we look at a blood sugar? Did we look at Narcan? Did we look at an overdose? Once again, most of the time you're not going to have a hypoglycemic or hyperglycemic or a overdose patient with retractions and accessory muscle use. However, we need to make sure we're doing all those rule outs. It's just as much of what are the treatable causes that we can treat this patient with other than just maintaining their airway. Why do they have the airway issue? Still need to be a little bit of detectives here. Questions, comments, concerns on that one or any of them? If not, we are complete. So if you guys don't have any questions, wait just a second here, but if not, you guys can all have a good day.